Good afternoon and welcome. I am Carolyn Hoytella, and I will once again be your moderator today. Welcome to Preparing for the New Normal Office Visit, the third module in our COVID-19 webinar series, Transitioning to the New Normal. As always, we are glad you could join us today and continue to hope that you and your families are staying safe. Thank you for all on the front lines who are helping to keep us safe and continuing to help us flatten the curve. A little bit of housekeeping. During the webinar, the audience will be muted since the webinar is being recorded. Several items, including the slides, are available in the handout section of the webinar module. You can access them at any time during the broadcast. In addition, all materials, including a recording of the webinar, will be made available on the Conventus website in a few days. Any technical issues, please reach out via the chat module and we'll attempt to address them as quickly as possible. At the end of the webinar, we'll have time for some Q&As, so please enter your questions into the question box in the webinar module. To those of us who were with us on our last webinar, last Thursday, any questions we did not address, we will be covering at the end during the FAQ portion of today's webinar. Little disclaimer, this presentation is intended as source of information on laws and regulations affecting medical practices and on programs to help businesses manage cash flow, liquidity, and operations during the COVID-19 pandemic. Neither Conventus or Capehart Scatcherd can guarantee the accuracy of information provided since statutes, laws, regulations, and guidance, as well as their interpretation, can rapidly change each day. Therefore, the presentation and any materials provided are not intended to be a financial or operational advice and is not a substitute for financial and legal advice from a professional who is aware of the facts and circumstances of your individual situation. We have a second disclaimer. As you've all who've been with us before see, you can read that. The objectives for today are stated here. We're going to explain the executive orders, guidance, requirements for reopening medical offices and resuming surgeries and procedures. We're going to provide practical strategies for reopening the new normal office and patient flow in compliance with New Jersey's executive orders, guidance, and requirements, and discuss the small business guidance for forgiveness of the Paycheck Protection Program. And we are going to answer those questions that were asked. Our speakers need very little introduction. We have Susan Lieberman, who'll be opening it up. She's the Vice President of Practice Resources here at Conventus, and Sheila Mintz, who is Chair of the Healthcare Practice at Capehart Scatcherd. So without further ado, I'm going to turn it over to Susan. Susan, please unmute your mic.
Carolyn, thank you for the introduction, and thank you for everyone for attending this webinar today. We know that this is a stressful time for everyone, and it's also very difficult to keep up with all the changing laws and regulations and guidance that is being given, and some of them are actually conflicting. So what we're trying to do for you here today is interpret that and help guide you with that. A lot of what we're going to be talking about, you may already be doing, but we wanted to put it in the context of the federal CDC and also state guidance and documents and requirements. So it is really a new normal. It's not, it's not after COVID. It just is the new normal. So next slide, please. We've already gone over the risk exposures and allegations in our last seminar or in previous seminars, but I thought it was really important to bring that back today because a lot of what I'm talking about and the strategies that you can put in place will mitigate a lot of the exposures and allegations that we have potentially identified as sources of claims and medical professional liability and workers' comp claims that you may be getting. Again, you know, if we're putting our patients and our staff safety first, a lot of this will fall into place. Doesn't mean that someone won't sue us, but a lot of it will fall into place. And we also understand that you need to balance it with business needs as well so that you can remain in operations. So without further ado, let me just start to talk about some of those things. I'm going to review it very quickly because we've done it before. So on the patient side of things, it might be a failure or delay or improper diagnosis or treatment of COVID-19, meaning that you should or shouldn't have realized that I had COVID-19, you didn't act quickly enough, or you didn't give me the proper treatment, including putting me on or not putting me on ventilators. There is some limited liability for that. We've gone over that in several of our webinars, so I won't go over that. There is limited liability to protect you against that and providers, but there are many gray areas. So it's not a blanket immunity from liability. And also, so I just wanted to let you know that. And right now, because you are the front line on the front line of this war, people are very grateful. But we also can't forget our non-COVID-19 patients. And there could be allegations of failure, delay, or improper diagnosis or treatment of acute and chronic conditions for those who have non-COVID conditions. And a lot of our non-COVID patients who've had chronic conditions or things that need to be managed just aren't being seen right now. And the other thing is an elective surgery that we're going to be talking about today. Obviously, there's infection control both for the staff and for patients that you didn't take proper actions. And we all know, we've all seen what's been happening on the nursing home front and the liability there. Next slide, please. Okay, so one of the things as we go along is with your employees, you know, you may have situations with your employees and we're giving you general guidance, but a lot of this is really specific to your specific circumstance. So, you know, consulting someone like Sheila or your personal attorney is really very important because they will say that there have been discriminatory practices or unsafe working environment, or that you were just plain old negligent in not putting the proper safety controls in your office. Other exposures could be false claims or promises that a particular treatment works when the evidence is against that. And also telehealth. We will be having our next webinar will be on billing audits, because while the OIG and the federal government has said they're relaxing requirements now and they're really not doing many audits now, it doesn't mean that they won't afterwards. The other thing with telehealth that I want to say, that other exposure, is that it is possible that there could be claims saying, well, you provided telehealth, but you should have known that I needed to be seen in person, or you did not follow up, or you should have stopped the telehealth visit and said, you know, I really need you to be in the office, or that you should have referred to a specialist. So those are those same standards of care still are applicable, even though we have some limited immunity from liability. And obviously, Sheila is going to talk about today when you have loan forgiveness programs, or you've gotten loans or grants, how to make sure that you can meet your financial obligations. Next slide, please. So as I said, it is very difficult to sometimes interpret and understand all the laws and regulations. I'm going to go over 3 of them, and 2 in specific today, because it really relates to you opening or reopening your offices, or if your offices are already opened, to make sure you're following what the state says you should be doing. And also if you're doing any procedures or elective surgeries. So let's go through the first one, the executive orders. As you know, on March 27th, Executive Order 109 said that we needed to stop elective surgeries and invasive procedures. They were suspended. Then on May 15th, the governor issued Executive Order 145, which it was effective May 26th, so this week, and allowing elective surgeries and procedures to resume, but only with certain limitations and guidance from both the New Jersey Department of Health and the Division of Consumer Affairs. So very shortly afterwards, on May 18th, the Division of Consumer Affairs issued an administrative order for that was effective immediately as of May 18th, and the guidance had two parts to it. One was for basically the Division of Consumer Affairs is dealing with unlicensed facilities, and that would be physician offices as well, unless you have a licensed one-room surgical suite, which is now considered a one-room ASC, but all else would be considered an unlicensed facility. And it has two parts to it. One is for any medically necessary or therapeutic services that you offer in an office, which is what you do. And so there's guidance specifically what you have to do when you open or reopen, or what you have to do now that you are opened. And the second is for any elective surgeries or invasive procedures you may be doing in your office that aren't in a licensed ambulatory surgery center, but you're still doing it in your office. So that's one. We're going to be going over that first. The second is from the New Jersey Department of Health, and they're dealing with licensed facilities, such as ambulatory surgery centers and hospitals. That was issued on May 19th, and obviously on because the executive order was effective May 26th, it is now, you must be following those guidelines as well. Next slide, please. So I want to really highlight some of the resources that I think are essential for you and that will give you a summary. We're going through some things in detail, but you will have these to go over at your leisure. I believe they are also in the handouts that are attached that you can print out in your menu bar. One of them is the Returning to the New Normal Office Quick Checklist. And that is just a summary of a lot of what we're discussing today, but in checklist form. Also, we have a risk alert on the new guidance on elective surgeries and procedures for COVID-19 during the pandemic. And a new one that we have, and we're going to be discussing this throughout this presentation, is we are recommending that if you're doing any type of procedure, invasive procedure, or surgical procedure, that you do have a separate informed consent from your regular surgical informed consent, giving them the risks and benefits of having the procedure during COVID-19. That has also been provided for you and is in the handouts, and we'll discuss why in a little while. Next slide, please. So let's start with the unlicensed facilities, which would be your office practice. Regardless of whether or not you're actually doing any procedures or not, you still need to follow the guidance set forth in Administrative Order 2020-07. And I've given you the reference here. Next slide, please. So the first part of that is really that administrative order is managing outpatient flow. And so that is the first section we'll go over, and then we'll go over if you're doing any procedures in your office. Next slide, please. So before we go on, I'm going to let you read the definitions at your leisure. I just want to point out two things again. In-person medically necessary or therapeutic services, which would basically be what you're doing in your offices to treat patients. So it would be in-office care, in-office visits. And then the second part of it would be the elective surgeries and invasive procedures, which they say are those that can be delayed without undue risk to the current or future health of the patient as determined by the patient's treating healthcare professional. And they specifically state that that excludes vaccines. So specifically for pediatric practices, or when we get a COVID-19 vaccine, that's specifically excluded from this elective surgery and invasive procedure definition. Next slide, please. So let's take it for I've gone through this presentation, follows the exact order of the guidance given in the administrative order, but I've also put it so that it flows the way, pretty much the way the patient would flow through your office, or as much as I could. The first thing that I want to say is you really seriously have to look at prioritizing your at-risk population. And the executive order states that you have to take a look at serious underlying health conditions for your most at-risk populations. So that could be your chronic care population, your COPD population, those kinds of populations, as well as those who may be at most risk for COVID-19. And it still says that when you can, you should offer telemedicine services if at all possible, rather than an in-person office visit. That's not always possible. So that's basically what they're saying. So want to make a couple recommendations. What we're trying to do throughout this entire presentation is give you some practical strategies of how to deal with these requirements by the Division of Consumer Affairs. So the first thing that I would say is what patient conditions are appropriate for you to see via telemedicine. We have been in, one day we were seeing patients in our offices, and literally it was like the next day it was turned off. And so you as practitioners have been trying to see your patients and do the very best that you can via telemedicine. But now you're going to have to think about what things can't I really, that really need to be seen. And if that occurs, what happens if the patient doesn't want to come in and you've recommended that I really need to see that patient? So I would suggest that be documented in the medical record, that you did inform the patient that they needed to come in, and in lieu of they've elected not to, they know the risks, and that in lieu of that, you are providing a telemedicine visit. So I would get that in, because if there are any allegations, at least we know that you offered, you told them that, I really need to see you for this one. You refused, you understand, and I'm still trying to do the best I can for you. You do need to identify your chronic care patients and any patients with acute conditions that need to be managed. How will you do that? Well, have you kept track of your cancellations or your postponements? Or if there are any chronic care management patients, can you utilize your EHR to help you identify those populations? Some of you may already be doing that. If you don't, go to your vendor and see if they can help you do that. Next slide, please. So before the office visit, we all already talked about, is it absolutely necessary? Do you need to see them? Then the Division of Consumer Affairs says that you need to be asking them questions about if they've had known exposure. Again, if your offices are open, these are things that you've been doing anyhow. The length of time since the onset of the symptoms or they tested positive. You need to advise the patient that they must wear a face covering. Either it has to be a cloth or a surgical face mask, except if it's going to inhibit their health. They have, for example, asthma, they can't breathe. They have COPD, and that's hard for them. Or the patient's under 2 years of age. Just understand that you're going to have to minimize patient-to-patient contact, which means that you're going to have to do things differently in your waiting areas. And this is going to decrease the volume that you're going to be able to have when you open or reopen your offices. And they do suggest that you schedule patients with known exposure or symptoms at the end of the day, or anybody you feel is in, that has been exposed to it. They really need to be either at the end of the day or when the fewest patients and staff are in the office. Next slide, please. Okay, so now we are looking at some recommendations. Use the CDC's phone advice screening protocol, and it is a script for your staff. If you don't want to use that script, you can have another script, but I do suggest that it be in writing so that your staff are consistent each and every time. You want to communicate with the patients up front a few things. Number one, your patients want to know that your office is safe and what you have been doing to keep them safe. In other words, having a safe office visit. So you want to have that messaging up front. Many of your patients may be reluctant to come to see you. Some of that reluctance can be mitigated if you're communicating with them. How are you going to communicate with them regarding this? Are you going to do it at the time of scheduling? Are you going to have a telephone message? Are you going to put it on your website? Are you going to do it via email? Your patients may not be technology savvy, so you may have to do it in a variety of different mechanisms. But things that you're going to want to tell them about up front is that they have to mask. You need to tell them your social distancing policies and your waiting time policies, how you're going to schedule, how they're going to be received, what's expected of them before, during, and after the visit. How many are you going to allow visits? What kind of follow-up? What kind of cleaning and disinfection? You should have office signage all over your office, reminding them of cough etiquette and hygiene, those kinds of things. You really, it's key to helping you open up your business and get as much volume as you possibly can, while both keeping your patients and staff safe. You might want to stagger your appointments to limit arrivals and departures. If you can, separate entrances and exits if possible. This is what the state is asking you to do. Next slide, please. Okay, so now the patient's arrived. Rescreening. The patient, the state says you must rescreen. Again, this is stuff that you're probably already doing, but they do want you to do no contact temperature checks or use thermometers with disposable covers, and then they want you to document that in the patient's record. They want a record of it. They're also recommending that the patients remain in their vehicles until they are ready to be seen. So how are you going to do all of this practically? So you might want to get no contact infrared temperature devices and CITs, or you have to have enough thermometers with covers. You need to make sure you've got enough. So there are all different systems, but you need to think about that and purchase that now. Some of them may be harder to obtain during COVID-19. Consider where you're going to rescreen and where you're going to do the triage. Are you going to do it when they come up to the registration desk? Or are you going to do it outside? Are you going to have somebody at curbside checking them in? Or are you going to have someone call them up when they tell you that they've arrived and go through that rescreening again? These are all things that you have to think about how you're going to do it. And I suggest you put it in writing so that everybody is consistent. Also, if we have to go to defend a malpractice suit, we have what your policies and procedures are. Consider the New Jersey Department of Health guidance for outpatient providers evaluating patients with COVID-19. So they're talking about how you do the testing, where you do the testing, and what kind of questions you should ask. And then again, you may want to consider either calling, telling the patient they need to call or text you upon arrival. And then you or a staff member, and you have to think about what staff member and what number you're going to give them to call and text you, and then that you're going to call and text them when they are ready, so that you minimize the time that they are waiting in your office. Next slide, please. So now we're at social distancing. And again, some of this you're probably already doing, but the administrative order by the Division of Consumer Affairs that says that your staff need to have their own workspace where feasible. That means not sharing phones, computers, pen, paper, medical equipment. So that would be your front office staff, that would be your billers, that would be all your administrative staff, not just thinking about your clinical staff, but your administrative staff. If that's not feasible, that's again when you might want to consider staggering, or now you're going to have to think about frequent disinfection. And not only is it okay to just say, okay, I'll frequently disinfect, how often are you going to disinfect? When are you going to disinfect? And who's going to disinfect? And those people need to be trained how to disinfect. Because I can tell you, I have seen in offices that they'll use the same Clorox wipe or whatever they're doing for many, many different doorknobs and many different phones. Is that, first of all, is that what you want them to do, is use a Clorox wipe? And second of all, you know, they need to know exactly how you want to do it. Patient registration and payment. They're telling you that you have to have a contactless patient registration and payment option. So if you don't have it, you got to think about how to get it. And they want you to distance between individuals, patients, and staff. They're talking about if you don't have a physical barrier in your reception area and in your triage and checkout areas, they're saying that you need to. As an alternative, they're saying if you can't do that, you have to arrange your intake and waiting areas to maintain 6 feet or more distance between individuals if possible. So you need to do one or the other, depending on what you can do in your office and what your finances are. I can tell you that the new guidance coming out from the medical community is that they're now starting to think that the COVID-19 transmission is not just from droplets, but it's probably aerosol and airborne, which makes a tremendous difference, which means that 6 feet may not be appropriate. And my guess is that 6 feet may be changed in the future. I'm not exactly sure when, but my guess is that the CDC may start to reevaluate that. The studies that say that it is 6 feet were in the 1930s, and we have learned a lot since the 1930s. So I've heard 12 feet, I've heard 20 feet, not sure what it's going to be yet, but if you can do curbside check-in, I suggest that you try to minimize anybody in your waiting area, or there's only one person at a time if you can do that. Again, you're going to have to see the layout of your facility and your office and what you can feasibly can and cannot do, but you really need to consider these things. Next slide, please. Okay, now we're talking about visitation policies, because now we're talking about the patients there in your office, right? Or they're coming to your office. And this is where you need to really communicate with them up front what your visitation policy is. You're going to save a lot of patient and staff dissatisfaction if you can do that. The DCA, Division of Consumer Affairs, the administrator order says that you need to restrict companions unless medically necessary to assist with the mobility, communication, or if a patient is a minor. And I want to dissect that a little bit, especially for your elderly and senior citizens. You know, their mobility may be restricted. They may not be able to communicate well. They may have hearing deficits. They may have visual deficits. So you really need to take that into consideration and allow a significant other to be with that patient, or if the patient is a minor. But you can limit that to one person accompanying them. And all companions must wear face coverings as well. Now, so that's again why you want to communicate this all up front. Either in those ways that we talked about, being transparent and communicating, but you may also want to remind them at the time of scheduling the procedure. If they do not come with a face covering, you're going to need to provide that for them. And I know face coverings are still pretty scarce, so you're going to need to make sure that you have enough to cover all of that if patients and or their significant others are not coming with a face mask. Isolation. They want patients with respiratory illnesses to be in a separate location or room They need to be put there immediately, so they can't even go into a waiting room if that's indeed what you decide to do, is have your waiting room open. They need to go into an exam room immediately, and the door needs to be closed. So let's go through some recommendations of how to implement all of this. As far as contactless registration and payment options, you still need to make sure that they are HIPAA compliant, because some of these may not be. If it's feasible, have your e-statements on your patient portal so that they can pay there, or you can have an EMV device. That is when you wave that card at a contactless terminal. I know they even have that, things like that on hotel doors now, that you just put the card there, you don't even touch the terminal. So those are options to consider. You're going to modify your waiting areas if you can. If you can't, I would do that waiting in their vehicle, or bring them in one at a time, and they need to be in a room as soon as possible. They want you to designate a COVID-19 area or room. So they want you to designate a specific room if you have that available to be able to do that. They want that done. You're going to have to decide upfront now which room you're going to do that in. And if you're doing that in a room, how are you going to, it has to be cleaned between each patient, but you have to have the specific protocols of how to clean that room. It's not just taking off the paper on the exam table or wiping the exam table down. It's the countertops, it's the doorknobs. We went through a lot of that at our last webinar, so you can reference that, but I've also given you references for cleaning and disinfection at the end of this section. By the way, I believe Carolyn has also put that in the handouts. All of the references that we have, we put together on one document so that it'll even be easier for you to see those references. So again, you're also going to post signage throughout your office about the social distancing, the hygiene, the visitation, and any other policies you have. The other things that we don't necessarily all think about is our vendors that may be coming in. So we're talking about limiting visitors with our patients, but also the vendors. There could be your pharmaceutical reps, there could be your computer repair people, your maintenance people, all sorts of vendors that you are coming in. How are you going to handle that? How many are you going to let in or not let in? Are you going to let them in when patients are there? Or do they have to come at another time, which would be feasible, preferable? And also when they come in the office, they have to follow the same patient safety protocols as the patient and staff with face masks. Next slide, please. Waiting areas, we've talked about that. If you do have a waiting areas, you have to think about your magazines, your toys, anything that you have in that waiting area really needs to be taken out because they're not easy to disinfect. You need to disinfect between each patient. The division says that you need to give sufficient break time. That means to your administrative staff too, because everybody has to keep washing their hands. Obviously, our clinical staff wash their hands before and after each patient, but so do your administrative staff, and there needs to be enough break times scheduled throughout the day. And the DCA specifically said they want you to follow the CDC guidelines for cleaning and disinfection, which we have given you at the end of this section, but they are especially concerned about high-touch areas, restrooms, countertops, doorknobs, water fountains, shared medical equipment. So everything that you're doing, and that's what we have in our recommendations, is you're going to need to educate everybody on how to do this. Who's going to do it and when, under what conditions, and what personal protective equipment they might have to use. So that is very important, and I would have that training of your staff documented in their personnel files that you did indeed train them adequately. You're also going to have to provide tissues, hand sanitizers, face covering. They want non-touch receptacles in waiting areas. That means garbages, and also in the exam rooms. And again, we've gone over this in previous webinars, but you need to have EPA approved cleaning chemicals that are specifically make claims against that they can be used for coronavirus. We talked about the training of the staff and ensuring everybody is familiar with these cleaning protocols. Next slide, please. Rigorous staff protection. So Sheila's going to go through this in more detail, but if you can, you need to accommodate telework if they can work at home, such as your billers or your schedulers, if they can. If they can't, we're going to talk about that a little later, trying to stagger the work schedules, and also for scheduling staff who have increased susceptibility to COVID-19. So that has already been identified by the CDC. So it may be people who have diabetes, immunocompromised, renal conditions, heart conditions, asthma, respiratory conditions, lung conditions, and there's a whole long list. You have to be really careful with your staff that you are not violating any ADA. There's no ADA violations, that you can't discriminate against them. But you need to make accommodations where you can. If you cannot, that's something else, and Sheila will be going over that. And also making sure that you have enough supply of PPE. The Department of Health for the ambulatory surgery centers has recommended that you have at least a 7-day supply of PPE in your office. So that's what I would, in your ASCs and hospitals. So that's what I would recommend in the offices. Next slide, please. Staff requirements, they have to be screened when they come in, and everyone needs to, at a minimum, wear a face covering. And we've gone over the different levels of risk in our previous webinar, so I'm not going to belabor that. We've given you references for that again. But you also have to train your staff on proper donning and doffing of PPE, because we haven't really done that on a continual basis before this. We're just getting familiar with all of this. Do recommend that you document the staff training of donning and doffing their PPE in their personnel files, and we are giving you training materials and where to get that. Next slide, please. Reporting requirements. The order says that you need to maintain a patient log just in case you need to contact trace. And if anybody is positive, you need to submit it to your local Board of Health or the New Jersey Department of Health. The other thing is, remember, we are the medical community and scientific community thinks that there could very possibly be a surge in the again, or an outbreak again in the fall. So you need to start planning for that now. So the recommendations are, you really want to start that planning and really anticipate your volume, know what your expenses are going to be, or at least anticipate that. Plan for the supply and evaluate what Sheila's going to be talking about is your staffing needs, the effects on grants and loans, depending on what staff you do or don't bring back. Next slide, please. So we've given you all the important resources that I've mentioned in the presentation, also in a handout. You'll look at that at your leisure. Next slide, please. Here is some training materials that I referenced from the New Jersey Department of Health and the CDC on donning and doffing PPE. Next slide, please. So now we're going to go into the second part of the administrative order for unlicensed facilities regarding elective surgeries and invasive procedures that would be in your offices if you are not licensed as a one-room ASC. Next slide, please. So this is what they're saying, that you need to, if there are any elective surgeries or procedures involving face, eyes, mouth, or high risk of aerosolization, and now we're learning that COVID-19 may be aerosol, airborne, borne. We're not, but they're saying that you need to defer if the patient is COVID positive or symptomatic for at least 7 days since the first symptom or 3 days after recovery. Just to know that that is, they're quoting the CDC guidance on that. They're saying to postpone for asymptomatic patients if unlikely to result in an adverse outcome. I'm going to tell you right now that the ambulatory surgery centers, even if the patient is asymptomatic, they are not allowed to do the procedure. So I would suggest that you really consider that higher standard of care in your office, because that will be questioned, and your motives for doing that procedure. Weigh and review with patients the risks of if they are identified at higher risk for contracting COVID-19. That's why a separate informed consent to discuss those risks is so important. We have given you a sample for that. They're telling you the kinds of PPE you need to wear and when, and that you need to disinfect surfaces between patients. And they specifically say for eye care professionals, you need to have a slit lamp breath shield barrier as large as possible. Next slide, please. So I've gone over a lot of this. Again, I would consider adopting the stricter ASC requirements not to perform surgeries on COVID-19 patients, positive patients, even if they're asymptomatic. The ASC and hospital requirements, which I will go over in a couple of minutes, require COVID-19 testing, and they require it to be at a maximum of 96 hours before the surgery or procedure. That includes collection, sending to the lab, and getting the lab results back. The DCA order does not specifically state that, but I would suggest you might want to consider that higher standard of care. You're going to need to evaluate whether you have drugs and PP enough, and again, consider stocking for the 7-day supply, because that's what the ASCs and hospitals are required to do. And we've already talked about the informed consent. Next slide, please. Now we'll go into elective surgeries and invasive procedures for licensed facilities. I'm not going into this in any great depth. I just want to let you know that there's a separate one from the Department of Health, as opposed to the Division of Consumer Affairs that we just went over for unlicensed facilities and physicians' offices. This is for licensed facilities such as ASCs, including a one-room ASC in your office, and for hospitals. They are very similar. The ASC and the hospital guidance is very similar. I will go over where there is any major differences. Next slide, please. All the same conditions apply. I'm not going to go through it about screening the staff, wearing masks, cleaning and disinfection, and planning for surges, but they do want the hospitals to review their capacity for a downward trajectory of COVID-19 cases for 14 days, and that to make sure that they have sufficient availability for in case there needs to be a transfer from or ICU beds and med-surg beds for those patients. ASCs must have a written transfer agreement with an acute care hospital, which most of you probably already do. But the caveat is that you must confirm and document before each day of surgery with your hospital that they have enough capacity in case you need to transfer the patient. Next slide, please. Hospitals must have a prioritization policy, and they have given guidance on what that prioritization policy looks like. It's level 1 through 5, going from life-saving to optional and minimal health impact. I'll let you read that on your own, but that may be why some of the providers on the call may not be able to do all of the surgeries they want. But just understand that COVID-19 positive patients can only receive level 1 through 3 procedures. They cannot have the very optional or selective procedures done. ASCs cannot have any COVID-19 positive patients at all. They have not been given guidance on what the prioritization policy needs to look like, but just that the governance body needs to establish one. Next slide, please. PPE is really the same as I've talked about before, but there needs to be sufficient PPE for 7 days, and staff need to be trained. all the same disinfection and supplies and equipment and all of that. They do say that you need to conform to the CDC infection control guidance by facility type. I've given you recommendation on how to do that, or guidance on how to do that with a link in your handout. Next slide. And here again, I need to stress this, that both for ASCs and hospitals, they need to test each patient within a 96-hour maximum before the procedure with a RT-PCR test and ensure negative status. So if it's 5 or 6 days beforehand, that's not good, you know. And they say that the patient must self-quarantine following the test up until the day of the procedure, and they have to wear a mask in their residence, they say, if appropriate, but they have to self-quarantine, and that you have to ensure that they are doing those things. That's going to be difficult. That's why we're giving you that informed consent to supplement your regular informed consent, because we have them attest to it in that informed consent that indeed they have followed that, and they're attesting to that. Same kind of visitor policy as we talked about before, you know, no visitors except for parents of minors or a support person. Next slide. There's hospital and ASC reporting requirements, and my recommendation to you is know your ASC and hospital policies and procedures. It's not good enough to just say, well, that was the responsibility of the ASC. You need to know where you're sending your patients. If you are an owner of the ASC, and I've given you 2 recommendations of where to go for prioritization policies for ASCs. I would strongly suggest that providers contact their patients who have been postponed, canceled, or canceled to ascertain their current status, because their prioritization status may have changed. Hopefully you've kept a record of that, or your EHR can help you identify that. And obviously you want your patients to know what the policies and procedures are of the ASC. Next slide, please. So here are some important resources that we have for you. And next slide, please. And also for the prioritization systems. I am now going to hand it over to Carolyn and to Sheila.
Okay, Sheila, thank you very much. You're up. If you can unmute your mic.
I have already. Thank you very much, and I'll do some speed reading. So let's do the next slide. I've been getting a lot of questions, and apropos of a lot of what Susan talked about, related to some of the employees that are the employee questions and issues, you know, coming back, and you know, and concerns about transmission of COVID to employees. There's an effect on this. It related to the forgiveness of the PPP loan, which many of you have gotten, hopefully, and I've been getting a lot of questions because there are a lot of there are a lot of issues related to people who don't want to come back, or you know, or you know, or are scared, or still have childcare obligations, or any of those things that Susan addressed a little bit. That there are issues involved, but there are also some effects on your ability to get forgiveness of the PPP loan. So let me just start on what the forgiveness is going to actually look like. With the SBA just recently issued this guidance talking about what the forgiveness, how the forgiveness is going to be handled, and what the application is going to look like. So the expenses that you can be forgiven for basically are in 4 different categories. So it's your payroll costs, which are not, you know, it's not that simple in terms of just saying, okay, your payroll costs. It includes all of these different things that are in that are on this slide. So including salary, wages, payments for vacations, parental, family medical leave or sick leave, allowance for separation or dismissal, payment for, or provision of group health care coverage and insurance premiums, retirement contributions to retirement plans, and then state and local taxes that are assessed on the compensation of employees. So keep in mind that your federal FICA and FUTA, the employer part of that, are not includable in payroll taxes. And generally, when you calculate the wages out, it's based on the gross wage. So that would include the federal income tax that is the employee part of it. This is meant to be, just so that before we back in, because I'm talking about a lot of complex, calculations, and this should not be the be all and end all of how you decide how to calculate your forgiveness application, because there's, each one of the practices have a little bit of a different situation. So use this as sort of broad-based strokes on some guidance to do this, but I would really suggest that you contact your attorney and your accountant to help you put this together so that you can get the greatest maximum possible forgiveness of your loan. So in addition to the payroll costs, the interest payments on any mortgage obligations for any lease obligations for personal property or real property. Personal property would be probably, like for medical practices, would be the lease of equipment or of any type of equipment, whether that be medical equipment or even something like a Xerox machine or a phone system. Again, payment on, rental payments would be appropriate also, again, on real property, which is the office space, or personal property, which is which would be equipment or lease on copier machines, phone systems, things like that. So whatever was in force on February 15th, those are the expenses that you could include. Also, your business utility payments for what they're saying, electric, gas, water, transportation, telephone, internet access would all be included in the forgiveness sum. So as a rule of thumb, you should be using about 75% of the loan proceeds for payroll costs and about 25% for non-payroll expenses. There are some ways that fluctuates, but basically if you use that as your general rule of thumb, you're going to be better off in terms of getting forgiveness, because there's going to be a lot of people applying for forgiveness on June 30th. Now, right now, just so that you know, and I'll address this later also, the application for forgiveness is supposed to be in by June 30th. However, the Senate is considering currently that they will extend the period of time during which the PPP money can be used from the current 8 weeks. So the final date for submitting the application for forgiveness may change, but I think that the standards and the way that you calculate it probably will not change significantly. However, I've been known to eat my words on this before, and sometimes they change things pretty rapidly. So before you start doing this, again, make sure you've gotten the most recent guidance and you're thinking about, you have professional assistance in preparing this. Next slide, please. Okay, so when you want to get the loan forgiveness, you submit an application to your lender using this SBA form 3058. Your lender also may have their own form that they want you to use, and if they do, then that's fine. You can use it. The lender then has 60 days to review your application, and once they've reviewed your application, they will submit the application to the SBA for review. The SBA will approve or deny. I mean, they're going to have their recommendation. The lender will have the recommendation to the SBA, obviously. The SBA will then approve or deny the forgiveness based on their own review. They will advise the lender will advise you. So if the loan is not fully forgiven, you will be required to repay any amount that's unforgiven in over a 2-year period at 1% interest. I understand, at least in the guidance that was issued by the SBA the other day, that there will be additional guidance that is forthcoming on appealing loans that have not been totally forgiven. Next slide, please. So the complication in applying for the forgiveness of the PPP loan is really in calculation of the payroll costs. I think the other expenses are pretty much self-explanatory. But this is, the payroll costs are kind of tricky. And there's been some additional guidance that, basically create some exceptions that people should be keeping in mind when they are making determinations about reinstating employees or furloughing employees and dealing with some of the issues that people are raising in terms of being unable to return to work. So as we said, the funds are supposed to, at this point at least, be used in the 8-week period that starts with the date of receipt of the money by the borrower. So payroll costs that are paid during that period, as well as payroll costs that are incurred but not paid during that period, are included in the cost. So basically, that depends on your time, the timing of your payroll. So you may have payroll that if it comes out like you're paying somebody for the 2 weeks prior, but the actual date of the payment is after June 30th, then you may run into, may have a question as to whether you can include that amount in the PPP forgiveness application. And the answer generally is that you can. There's a lot of very complicated, there's like a page full of standards and different methods for calculating payroll costs that you need to pay attention to when you're actually doing it. But generally, whatever pay periods fall within that 8-week period, as well as salaries and wages that are earned but not paid during that period of time, are generally includable. So also includable are salary or wages paid to furloughed employees, bonuses or hazard pay during the covered period are eligible for loan forgiveness. So, we know that they've been talking at least about, and some of you who are on the front lines in treating COVID patients may be giving your staff or your employed physicians a little additional incentive pay for some of the hardships that they're incurring, and that also can be included in the loan forgiveness application. However, the salary or wages that are paid can't exceed the prorated annualized salary of $100,000. So, and we've talked about this before in other webinars, but it still is kind of a sticking point. So, basically, the base salary, if someone is making $150,000 a year, for example, you can only pay the portion of their salary based on $100,000. So basically, not to say that you can't pay them the additional $50,000 or the additional prorated amount on $50,000. Keep in mind that this is all prorated on an annualized basis. But you cannot pay it from the PPP loan proceeds, and you can't reflect any additional payment of salary in excess of $100,000 on the forgiveness loan, the forgiveness application. However, at least based on my reading of the guidance that was released by the SBA, again, which may change between now and June 30th, any additional bonus or hazard pay, which can be included, that would drive the salary or wages in excess of the annualized basis of $100,000, is still forgivable. So, so that just keep that in mind if you're giving people bonuses, that even though that might create a situation where they're, if you include salary plus bonus, they're at an annual rate of over 100, you still can include the bonus or hazard pay in addition to the salary that's paid. So the way the CARES Act, which established the payroll protection program, it worked that they would reduce the loan the loan amount, the loan forgiveness amount based on a number, based on basically employee headcount. So it's the full-time equivalent employees that are on staff as of June 30th, 2020. This is where it gets tricky. Anyway, next slide, please. Next slide. Carolyn?
Are you not,
Okay.
Sheila, you not seeing them?
No, I didn't see it. So yeah, it wasn't moving. So I see it now though. I'm fine. All right. So the generally, if your head count of full-time employees on June 30th has to be the same as it was basically on February 15th. So if you have a change in that, or if a reduction in the head count, then that may reduce the amount that you can apply for loan forgiveness for. But if you have an employee who refuses an offer to return to work, you can still include their salary in a loan forgiveness application. Now, keep in mind, this is not an employee who this is an employee who was furloughed and who's been getting PPP, not an employee who is, well, all right, let's start with that. The employee who's being paid by PPP, you're asking them to come back to work, and you're then making an offer in good faith. I would suggest making it in writing. The offer is basically for the same hours and salary, and the employee refused to work for one reason or another. I've been getting a lot of questions about employees that cannot come back to work because they have childcare obligations, they have no daycare, there's not going to be summer camp very likely. They have no child care assistance at all, so they cannot come back to work. In that case, they may be eligible for still be eligible for unemployment, still be eligible for Family Leave Act coverage under the federal act. But so the salary of that person, as long as those various terms are complied with, can still be included in the PPP loan forgiveness application. So even if someone has had their employment terminated because of their refusal to work, really for any reason, then as long as you have documented the offer, your offer is for the basically same salary and hours, and they refuse to turn to work, and you document the refusal. So I wouldn't just do email. I would do a letter to the person saying, we've offered you the ability to come back. You have refused confirm it. You have refused. You have childcare obligations or whatever the reasons are. And then you notify the unemployment office of the refusal of that person to return to work within 30 days of the refusal. Under those circumstances, you can include their salary in the PPP loan. Also, anyone who's being fired for cause or who voluntarily resigns during this pandemic can also be included in the application for their salary, can also be included in the application for loan forgiveness. Next slide, please. Okay, so only when you submit the application for loan forgiveness, you only need to submit the application. You don't need to submit all of the records with them. However, you better have the records. You need to have records of all the expenditures, and that's why we talked in some of the last last webinars that immediately, as soon as you start receiving the grants and loans from different sources, most medical practices have received the PPP loan along with payments from HHS. That both of those you need to really keep track of it, and you need to keep track of the expenses separately, and you need to make sure that you're not double dipping, that you're not paying the same expense out of both grants, because they will check to see how the payments merge together. So you want to make sure that you're not doing double booking or anything like that to make sure that you have clean records when and if the SBA or HHS comes to visit you and asks for that documentation. The SBA has announced that any business which received $2 million or more in PPP funds will be audited. I don't anticipate that many private medical practices have received that much money. Even the larger practices, maybe like the very large super groups, I'm sure would have, but they also would have the billing staff to be able to put together adequate records. But just keep in mind that they may elect, sort of on a random basis to pick businesses that will be audited. So I would just assume that there's going to be questions about how the money is used at some point in the not too distant future. So I just keep records of how this is all working, and don't just make it up and kind of fly by the seat of your pants on this. Next slide, please. Okay, so there was the one thing that this also kind of goes with you want to talk about the FaceTime? You want me to talk about the nurse practitioner part first?
Why don't you go ahead and keep talking about the nurse practitioner, and then I'll jump up into the FaceTime one, Sheila. Thanks.
Okay, that's fine. So, just this kind of goes along with what we had talked about in PVP, and I've gotten a lot of questions related to people who are saying, well, I can't come back to work because I have childcare obligations, or I need to, I have someone that I'm caring for, or I have a comorbidity, or I have a medical condition that would not allow me, that would make me more susceptible to a serious version of COVID-19 if I come back. So someone is afraid to come back. So you can ask a person to come back. They can refuse. Again, there's no indentured servitude, no one here, in the United States. So you need to, if someone does that, you can terminate their employment. But keep in mind that there are other issues there are other programs that people may be entitled to obtain. So if someone has family, has children at home who are out of school, they may be able to apply for FMLA status under the Federal Act and retain their job and be employed and retain their salary for a 12-week period. If they're caring for an ill family member, they may be able to apply for New Jersey Family Leave Act, which would provide them, which is similar, which is applied through the unemployment through the Department of Labor. The same way that unemployment is. So all of those things may be a possibility. You need to advise and work with each of these employees sort of on a case-by-case basis before you just sort of terminate their employment, because you do possibly subject yourself to to a discrimination lawsuit, generally I found the Department of Labor has a very good spread, like a checklist with COVID-19 scenarios on it, which I think we've provided to people before, and it may be on Conventus's website, but I can certainly provide that to people if you can't find it. But it is right on the Department of Labor's website, that goes through various scenarios of what benefits people may be entitled to under the various scenarios that they don't come back to work. But the main thing that you don't want to do is you want to document as much as possible what the reasons are, what the response has been, and how you've dealt with with the situation, and get professional advice to to deal with this, so that you're not subjecting yourself to either a claim under the ADA or or the Department of Labor, or a wrongful termination suit. And I will hand it now over to Carolyn to do the HIPAA compliant form of healthcare. Susan, sorry.
No, it's Carolyn. Thank you so much, Sheila.
Okay.
We had a question last time just about, is FaceTime a HIPAA compliant form of telehealth? And the answer is clearly there. Under normal circumstances, when we are not in a public health emergency, it is not. And again, Medicare is the one, the Centers for Medicare and Medicaid Services, who set the standard for what can be done. But as of March 17th, with the public health emergency, CMS has allowed popular non-public facing communications to be used. And the key here is that they are saying that it can be used for telehealth services without the risk that the Office for Civil Rights may impose penalties for non-compliance with HIPAA, meaning it does not meet HIPAA standards. But keep in mind, this is just a light guidance, and that things change. So next week, please, for those of you who have followed us, come on back. We're going to have a webinar that will focus on the future of Medicare telehealth audits. There will be audits. And what we're going to focus on there is looking at overall what practices are doing with telehealth, and the fact that you need to have a formal telehealth product. This is a great substitute for today. But moving forward, you're going to have patients who may or may not want to come back into your office. It could be because of an existing health issue. You need to think about a product that truly is built on a platform for remote patient monitoring and for telehealth. And this will speak directly to the patient safety issues and the ability to provide that continuity of care that is going to be needed. So please stay tuned. We are going to have that. And we have a couple questions, because I think we have a few minutes. We can squeak one in. Susan, there's one here for you about how would you handle your cleaning service?
Thank you. So you need to contact your cleaning services, because not all cleaning services are created equally. And here's some of the things that you might want to discuss with them. What kind of cleaning agents are they using? They need to use ones with claims that they can be used for coronavirus disinfection. So that's number one. Number two, you need to make sure that they have that the cleaning service has the proper PPE. And number three, you want to make sure that they have a copy of and understand the CDC guidelines for cleaning and disinfection. And then you're going to have to think about how you're going to supplement during the day, because you're not, unless you have the cleaning service there all the time, how you're going to supplement during the day with your staff with the cleaning that needs to be done between patients.
Terrific, thank you. There is another question, Sheila. There's one question here about, we're going to take only one part of it. Is there a reference for physicians over 65 years of age returning to an office even without a pre-existing condition? So they don't have diabetes, let's say.
For a physician?
Yes. So is there any reference, that can be used for a physician who is over 65 and is going to be returning to work, I'm assuming in the medical office, even without a pre-existing condition.
Right. Well, I mean, I think, you want to take there isn't there isn't anything particular that I've seen related to a physician over 65, but generally you want to take the precautions that that you would normally take. The fact that, if there are no other comorbidities, then that's a good thing. But if there's a question related to, whether that person should, it really depends on whether the physician feels safe in coming back and performing services, and what kind of services are being provided, and whether whether you're dealing, whether the services that you're providing can be provided via telehealth, because those are things that you want to, if that can happen, then that's good. Are the services that are going to be provided more likely to bring somebody into very close, face-to-face contact? All of those things I think are things that you have to look at. But in dealing with, I think my general feeling in dealing with any of the personnel issues is first to sit down and talk it over, basically, to see if there's a way that that the concerns can be accommodated, rather than just sort of saying, okay, you're out, or you can't come back, or something like that. Because the more people get their backup, the more likely that is to result in a claim. But generally, just to see if there are concerns that can be addressed and be accommodated in a reasonable way, and then go forward from that standpoint.
Okay, terrific. Thank you all so very much. We are out of time. We always run that close. Please join us next Friday for our webinar that will focus on the future of Medicare telehealth audits. It will absolutely do that, and it will also talk a bit about some of the new, some of the laws here that have changed a little bit about providing telehealth. Thank you all. Please stay safe, and please have a great week. And we hopefully will see you or talk to you all again next week. Sheila, your closing?
My closing, don't forget to wash your hands.
Thank you all. We'll see you again.
Okay, thanks. Bye-bye.
Bye-bye.